Good morning, everyone, good afternoon, or good evening, wherever you might be watching. Welcome to the fourth day of the second edition of the International Aesthetic Masters. Today we kick off with a big friend from Spain and one of my mentors, Dr. Miguel Roche. Miguel got his degree from the University of Barcelona and then, after some years, his PhD title in Clinical Techniques in Dentistry and Stomatology by the same university. Dr. Roche has published more than 50 articles all through the years in this field of aesthetic dentistry and endodontics, and is professor and chair of the Department of Restorative Dentistry at Universitat Internacional de Catalunya in Barcelona, Spain. Miguel was also the president of the 2015 biannual meeting of the European Society of Endodontology, held in Barcelona, and is now the president-elect for 2019 Aesthetic Dentistry World Meeting of the International Federation of Aesthetic Dentistry, also to be held in Barcelona. Dr. Roche will present a very interesting lecture on how to ensure a good management of compromised teeth in the aesthetic zone. I am sure you will love his lecture.
My name is Miguel Roche and I'm very happy to be here in this extraordinary meeting that Joao has organized for us, Joao and Rui. And it's a honor for they have put together an extraordinary group of people, so I don't know what I'm doing here. Anyhow, I will try to explain you, as you will see later, how do we work with severely damaged teeth in the anterior zone. We know that the implants do have problems, but and although they are extraordinary mean to treat missing teeth, but many times trying to save teeth helps us a lot. During the lecture, I will try to show you this concept. The topic for the lecture is treatment planning for severely damaged anterior teeth. As I told you before, I'm Miguel Roche and I'm professor and chair of the Department of Restorative Dentistry and Endodontics in Barcelona at the Universitat Internacional de Catalunya in Spain. This is a case that it's not strange, a type of case that is not strange to see in our offices. This is a 30-year-old girl who had an implant placed several years ago, and it's a failing implant. It has periimplantitis. You can see the metal through the gums. It's an extremely difficult case to treat, and it's not so strange. In fact, this patient, I won't show you how she now, but she has gone through 3 surgeries. She has been wearing orthodontic appliances, so she's spending money. She's experiencing pain, and still the result is not optimal, because solving these cases it's not easy. So it's key you understand that implants do have complications, and the list of complications that implants can have is very long. We won't enter in detail in all of them, but let me just in a fast way comment 2 of them. First are aesthetic complications, and let me show one of the very first implant cases in the anterior zone. This implant was placed by Dr. Basilio and me in 1988. Remember, we finished our dental studies in 1988, July 88. So we have been working for less than a year at this time. Okay? And you see that the incisal edge of tooth 1-1 is significantly higher than tooth 2-1. And be sure that at that time, as I was not experienced, but I was not that bad. And my dental technician was not that bad either. You see that the bone is okay. He lost not much bone in 17 years. And when we remove the screw, you see how old the screw is, we see that tissues are in excellent condition. Why this did happen? You might tell me, okay, probably the girl was 25 at the moment we placed the implant. Maybe you placed the implant too soon. You should have waited longer. That's what we thought at that time, so we decided to replace that crown for a new crown. She has economical. Remember, throughout the lecture, when I take a picture to a mirror, I don't turn it, so it's in the opposite side when it's a picture to a mirror. Okay, so we placed it in a study that it was on zirconia crowns, so these were the first lava crowns we placed, so she had not to pay. It's not very nice, I know, but at least incisal edges are leveled. But 10 years later, again, there is a change in incisal edges. Why does it happen? Why did this happen? Well, now we know that there is a continuous growth of the alveolar process throughout life. And as there is no periodontal ligament through around implants, they are ankylosed to bone, so they do not move. This affects every single patient, but it's more significant in especially females with long face. So you have to place an implant in the anterior zone to a female long face, exposing her gums. That might cause problems. She has to be aware that she will probably need to replace the crown and probably go through some periodontal surgery in the future in order to maintain a good aesthetic smile. Other problems we have with implants are periimplantitis, which was to set poorly documented. It was said that it went around 5 to 8%, but there is a very interesting paper published in Journal of Dental Research in January 2016, titled Effectiveness of Implant Therapy Analyzed in a Swedish Population, Prevalence of Periimplantitis. Remember that Swedish population is probably the population where implants are better controlled, for they are supported by the national health system, and the patients have to go to checkups in a routinely in order to maintain the support of the national health system. Okay, in this environment, the presence of periimplantitis was found in 45% of the implants after 9 years. That's very high. That's very high. You might say, well, maybe they were too strict in considering periimplantitis. Okay, let's take only moderate to severe periimplantitis. It affected 14.5% of the patients after 9 years. And those are high numbers. Those are high numbers. We have to think that implants do have problem. In the same journal, in the editorial, Lang and Gianobili wonder whether implants are a panacea or should we better strive to save teeth. And after reading the literature, they conclude that teeth even compromised because of periodontal disease or endodontic problems may have a longevity that surpasses by far, and I will insist you in this by far, that of the average implant. So we can say that prognosis of compromised teeth is better than that of an average implant. That means that we have to remember what Cervantes made Quixote said in 1605. He says that every tooth in a man's head is worth more than a diamond. So we have to keep teeth in the mouth whenever that is possible. Because, and I repeat it, the prognosis of a compromised teeth is better than an average implant. For that reason, it's key that we revisit the long history of success of tooth maintenance to preserve the natural dentition without the rush to extract teeth and replace with implants. There are many techniques in dentistry that do work, and mainly because of implants, we are not using anymore, and that's, from my point of view, a mistake. And of course, there are conditions that may lead to tooth extraction: dental decay, periodontal disease, crown root fractures, failing root canal treatments, dental anomalies, dental resorption. But there are many dental techniques, many treatment options from an endodontic point of view, from a restorative point of view, from a periodontal or surgical point of view, or from an orthodontic point of view, that allow us to save many teeth. The list could be much longer. During the lecture, we will cover cases where we use all the techniques I'm showing you here. But there are many more. And as you have to understand, it's impossible for a standard dentist to be able to deliver to his patients, all these treatments that the patient will need. And we need to be able to deliver these treatments to our patients in order to provide them with the standard of care today available or today established. Because our patients deserve the best. And the only way we know we can provide our patients with the standard of care they deserve is by an interdisciplinary approach. It is key to work as a team. Not you do the perio, I do the endo, he does the ortho. No, we do the perio, the ortho, and the perio. Of course, perio will be delivered by a specialist in perio. Ortho will be delivered by a specialist on ortho. But we all discuss together what to do, and we all need to know the possibilities that other specialties can give us in order to provide the patients the standard of care they deserve. So, we can say that implants are an excellent tool to replace missing teeth, but preserving teeth is better. That's what we will try to explain throughout the lecture. When deciding to save or not a tooth, we have to consider general aspects from the patient, that is, gingival display, aesthetic demand, patient age, economical budget, patient's compliance, patient's health. We need to pay attention to all these items. One very important for us is patient age, because depending on patient age, many times we try to gain time. Gaining time is an excellent option in many situations we will find. And apart from general aspects of the patient, we have to consider specific aspects of teeth, such as restorability, crown-to-root ratio, ferrule, or access to the lesion. We will discuss a little bit all these concepts, starting with restorability. First thing we have to ask ourselves is whether a tooth is restorable or not. If we think it is restorable, we need to think in how will we access the problem. Sometimes we will need to do an external access, which is by far the easiest one to do. or the easiest one to achieve. Other times we will need to gain access from the interior of the tooth. Other times we will need to raise a flap in order to access the problem, that's surgical access. And finally, there are situations where we cannot see a way to access the problem, so we have no access. Let's put some examples of every one of them. As I told, the easiest one is external access. Let us see, comment for instance this class 4. This is a young patient who broke the incisal edge of his central incisor and wanted to have it restored. We have materials that allow us to directly restore these with an excellent result. We know that layering composites, we are able to reproduce nature and to obtain an excellent biomimetic result. We can copy the function and of the neighbor tooth. We can capture the color, we can capture the texture with this material. Of course, we need some trainment, but materials we can use now are excellent and allows us excellent results. Anyhow, these materials are plastics, so they change color, especially when you don't manage them so well. That's why this patient, she's a young periodontist. Well, she was resident of periodontology in our school. She had these composites in his interiors, in central incisors, maxillary central incisors, sorry. And she wanted to have a more reliable result, and she asked us to deliver her to porcelain veneers. So we removed the composite, and without preparing teeth, we took an impression with which our technician prepared two feldspathic veneers. This is 1 month after cementation of these veneers. This is a 1 year control. This is 2 years control. So after 2 years, we have an excellent integration in the tissues, an excellent integration aesthetically, functionally. So they do work. They are excellent materials, and it's an excellent treatment. Of course, we need a good technician, but external access makes things much easier. There are other situations where the access has to be internal. We will present 3 different cases. First case is a 40 years old lady who had been wearing crowns in her 4 maxillary incisors, and she came to us after visiting several dentists, for she had a sinus tract apparently coming from tooth to tooth. We took an X-ray and we can see a radiolucent lesion in the apical part of tooth to tooth. Anyhow, we did a fistulography, and we see that the tip of gutta perca does not point the tip of the root, but the tip of the post. Seeing this, we can think into possibilities. First, root fracture. If that's the case, the tooth is for sure lost, or tooth perforation that has been there for many time and now has caused the infection, or the sinus tract for the infection was already there, of course. So we take the patient, just in case it is a perforation and not a fracture, we might be able to do something for your tooth. Anyhow, we need to know that, sorry for this misspelling in extraction, we need to know that if we pull this tooth out, if there is a fracture, it will be very, very difficult to place an implant immediately. We will need to do a preservation there, and of course the result will be more compromised. Unfortunately, we didn't take a CBCT. She brought this CBCT. It was in paper, so it was not the best way of looking there. she didn't want more radiographs, so we have to work with that. I told Dr. Fernando Duran, who is my endodontist, to remove this crown and then check with the microscope if he saw some fracture or just a perforation. He could see no signs of fracture. So finally, he thought that it was he did see a perforation, so he treated it as a perforation. So after cleaning and shaping, he filled the apical third plus the perforation with MTA and sent the patient back to me the same day. Of course, we work with complete isolation with rubber dam. This is the real situation. So there is no decay. The crown has been there for 20 years without ferrule, but there is no decay there. So it's not a good option to place a crown there unless we are able to provide her with ferrule. The problem is to convince her that something that has been working for 20 years cannot be repeated. Anyhow, at that moment, what we decided is to place a post and with a silicone index placed in a bulky way, also all composite in a single use, place it there. We didn't think in aesthetics there, so don't expect an excellent result with this, just we wanted to do it fast. Patient was tired, we were tired also, and we wanted to finish. Thinking that it's a temporary restoration. We set the patient to come back to a control, but she did not come until 6 months' time. Of course, you see that the static result of this restoration is not good, but it's not layered, it's a bulk composite. We could do it here, for it's a flat surface, so the configuration factor is very favorable. It's the configuration factor is 1. So it's excellent. It allows us to do this. Okay, we see that there are no signs of sinus tract there. We take a radiograph and we see that in the radiographs in only 6 months the lesion is also disappeared. I will go back, sorry, I went too fast. The lesion has almost disappeared, radiographically, of course. So we proceed with the rest of the teeth. We saw that all the incisors had lesions not shown in the periapical radiograph, but shown in the CBCT she brought to us. We did also restorations in bulk with composite. And at this point, we explained to the patient that placing crowns here was not reliable at all. That the ideal thing to do would be to do some, or either crown lengthening, which would be not very static, or some orthodontic extrusion in order to gain some ferrule. She went to orthodontist to do that, but unfortunately, the orthodontist finally and her decided to treat orthodontically the lower arc, but do nothing in the upper jaw. So she came back to us and asked us to place crowns directly on those teeth. We said, no, we are not going to do that. It's not reliable. We said, okay, they were there for 20 years. So I want them to be done. Either you or other will do it. I prefer you to do it. And if they fail, I will accept the failure. So she signed up that, and we went for the crowns. And this is the 6 years follow-up of those crowns. Okay, occlusion is very favorable here, and that helps. But we have a reasonably good result after 6 years with teeth that had a very, very bad prognosis. We are always in time to place implants. We offer her the option of extracting the teeth and placing an implant, especially in tooth 2, but she said no. Why? I want to have my tooth there as long as possible. The second case is a very young girl. It's an excellent friend of my daughter She's 24 as my daughter. They went together to kindergarten and through all school and high school. And she came because they were going to a wedding and she wanted to have a bleaching in order to improve her aesthetics and find a good boyfriend, I think. So she came to the office, and as soon as we saw that pinky aspect in the cervical third of the crown, and we immediately thought in the possibility of an invasive cervical resorption. So instead of going for a periapical radiograph, we went directly to a CBCT, and this is what we see in the CBCT. There is a huge lesion. It's a Heidersheim class 4 invasive cervical resorption. We see that the entry of the lesion is very small. She told us that she had gone through dental bleaching a couple of years before, not with us, and that might be one of the reasons that cause it. Anyhow, there are patients that have this without any trauma or orthodontic treatment, not bleaching. So sometimes it comes up spontaneously. Okay, it's a tooth with a very, very bad prognosis. The tooth is vital. Let's say the tooth is vital. For you know that predentin, you can see it in here in the radiograph, is extremely resistant to the advance of the resorption. We told the patient that we thought that the tooth was going to be lost, but in the meantime we had to try to make it last as long as possible to gain time, the more we can. So we decided to do a root canal treatment and thoroughly clean the inside. We made a slight mistake in here because the wedding was to happen in a week or so, and as long as it was a friend, we changed the protocol. We usually treat these lesions when we access internally with calcium hydroxide, but in this case we saw that the lesion was the entry of the lesion was so small that Dr. Duran decided to do it in a single session with 90% trichloroacetic acid. So he placed the trichloroacetic acid, leave it for some time in there until everything disappeared. With the microscope he was controlling the lesion, and finally he filled it with SDR and a composite. But the trichloroacetic acid burned a little bit the gum and caused a recession. I don't have the picture with me now, and because of that recession we needed to do a gingival graft. So the case was more difficult, but this is 1 year later, and after 1 year you see the tissue graft here, which is working fine. We see that the result is excellent. I don't know how long will it last, but every year we gain is like gaining an important match. And the day we place an implant, if we have to place an implant someday, the prognosis will be much better than now. Third case, again, asymptomatically, in a routine checkup, we see this lesion, tooth is vital. It's again a Heidersheim class 4 invasive cervical resorption. The lesion is huge. The entries to the lesion are small. No way you're entering through there to try to clean the lesion. So Fernando opened up the endodontic opening, a small endodontic opening, tried to clean as much as he could, placed calcium hydroxide twice. So she had the calcium hydroxide for 15 days 2 times, that means twice, that means 1 month. And after 1 month, we fill it with gutta-percha and we close with SDR and a composite. This 2-year follow-up, you see how our filling material, there is, sorry, a bubble there, it shouldn't be, I apologize, but we won't do nothing about that. We see that the filling material has filled most of the canals, of the lateral canals of the restoration. Look at this one. Excellent filling. And this is the 3-year follow-up. It looks perfect. We might have a problem sometime through here. It might happen. I don't know. We have to control it every 6 months. That's what we do. But we gain a lot of time. And we are very happy about the result. At times, the only way we can access the lesion is through a surgical access. We have a young patient who came for a routine checkup to our office. He was 18 years old at this time. He was neighbor in our building of our office. He lived in the building where my office is located, and we can see again a pinky aspect in the cervical zone of tooth 1, 2. We immediately think in an invasive cervical resorption, so in this case we took an X-ray and we see the huge lesion. This time seems not to go apical, to stay more in the cervical area of the tooth. So we decide to take a CBCT. In the CBCT we clearly see the extension of the lesion. You see it there. The lesion is really extends. Oh, sorry, I wanted to stop it here. Apparently it affects up to the pulp, but the pulp is intact. The tooth is vital here. You know, well, we know from the literature that predentin, a thin layer covering the pulp, is extremely resistant to the advance of the resorptive lesion. So the tooth is vital. What we like to do in these cases is, apart from seeing the CBCT, is doing a segmentation of the tooth. We will talk again on tooth segmentation later on. And from the CBCT we're able to build a tooth. So this is the real tooth. Of course, in this real tooth you are seeing the root canal. The thin layer of predentin is not shown here, but there is a thin layer covering the pulp canal. So the tooth is vital. It's important to know that. So seeing the segmentation, we are able to see that we think, at least we think, that this tooth is restorable. So there is enough tissue to support the tooth in long run. So we asked the orthodontist to start his orthodontic treatment, and instead of trying to level all teeth, we told him, please bring this tooth forward as soon as you can, as fast as possible. Then we raise a flap, and we see that the lesion is exactly as we saw it in the segmentation. Then we do a complete isolation with rubber dam. We thoroughly clean the lesion, not with bars, but with 90% trichloroacetic acid, and then we proceed with a conventional restoration. Sorry, I go fast in here. It's important that the type of composite we place is a nino hybrid, and then it's also important to thoroughly clean it, to thoroughly polish it, for it will stay under the gums, and it's extremely important that it's very well polished in order to reduce bacteria attachment on its surface. Later on, the patient continues with the orthodontic treatment. We ask the orthodontist to try to extrude a little bit this tooth in order not to have so many space of composite under the gums. The tooth remains vital. We see some resorption in the tip of the root as a consequence of orthodontic treatment, and this is a 7-year follow-up. Tooth remains vital. The gums look nice, although we have some composite under them. radiographical looks fine. So we offer the tooth an opportunity, and it seems is working well. And finally, there are situations where we see no way of accessing the lesion. In these situations, sometimes we still have an opportunity, and the opportunity is called intentional replantation. Let's see a case. This patient, 35 years old patient, comes to our office. She referred to us for they saw a sinus tract. It's not very well shown here in the picture, but there is a sinus tract in here. In a periapical radiograph, we see some radiolucency. There's a radiolucent lesion in the mesial aspect of the tooth. No apical signs. Tooth remains vital. We take a fistulography and we see that the tip of the guttapercha directly points that radiolucent lesion in the mesial aspect of tooth 1-1. We take a CBCT, and in the CBCT we clearly see the lesion affecting the cervical part of the tooth, but it goes straight mesially, so there is no way, either raising a flap, either with surgery, to access that lesion. So unfortunately, we commend the patient that with that tooth will be probably lost. Maybe we will need to extract it now, but it will finally end up with a problem. And the problem is you already have a fistula sinus tract there, and doing the root canal treatment will not solve that problem. So we need to do something. So we say, well, the only possibility we see is pulling out the tooth, trying to clean the lesion, and if everything runs well, replant the tooth in there. But remember, we say the patient and make sign the patient that in the extraction process or while trying to treat those lesions or that lesion, it might end up with an extraction, and then we will need to go for an implant. And when she accepting going for the implant, we start and do our root canal treatment. We like wave 1 files very much. Reciprocating files do, at least in our hands, very well. It's a reliable procedure, it's a fast procedure, it's an easy procedure. And once the root canal treatment is done and filled with thermophil, then we carefully start with the tooth extraction. Once the tooth is extracted very carefully, we cover the root with a gauze full of saline, in order to try to save all the cells, to keep safe all the cells of the ligament, periodontal ligament on the root surface. And then we take a bar, thoroughly clean both the access to the root canal treatment and the access to the lesion. Once the lesion is clean, we proceed with our routine adhesive procedure. Look where the lesion is under the CEJ, cemento-enamel junction. We fill it with nanohybrid composite, which is very, very, very well polished. And then we replant the tooth. We stabilize it with a suture there. And this is the tooth 2 years later, I think. It's working well. This is 2 years control. No signs of the sinus tract. This is 3 years control. No signs of sinus tract, no signs of inflammation. It's doing pretty well. Another case. This 10 years old girl, she was referred to us by her orthodontist in London. She spends some holidays in Spain from time to time, so she had an apparently a flare-up coming from tooth to tooth, so she told us to do root canal treatment. We did the root canal treatment, but it failed. Patient came back to us some months later with a new flare-up. We took a CBCT. In the CBCT, we saw that it was not an apical problem, but it was caused, the problem came from the distal aspect of the tooth where there was a huge lesion. I'm not showing the CBCT here, sorry, you will see afterwards. So we came to the conclusion that the tooth needed to be extracted, but remember the patient was 11 years old at the time, 11 years old. If we extract the tooth there, we will cause a severe problem. So what we did is we decided to extract the tooth. Once the tooth was extracted, we saw the lesion. We knew the lesion was there for the CBCT. We did an epiectomy also, and we filled the lesion with nanohybrid composite, which was very well polished, and then the tooth was replanted. Periodontal ligament was recovered, and the tooth did very well. So her orthodontist started the orthodontic treatment of the upper jaw, and this is the 9-year follow-up. This is last April. You might say, well, there is a mild inflammation here. I won't say no. It might be there. I won't probe in there, just in case, because you have a long epithelial junction. It's better not to probe there. But the thing is, this is 2008, this is 2017, 9 years later. The patient is now 19. No signs of infection. The CBCT, you see nothing in here. So we try to gain time. We know this may fail, but this is working excellently well. The situation now for an implant, this patient had menarche very young, at the age of 12. So she's a short face, so probably if we go for an implant, it would last long time with an excellent static result. But the more time we gain, the better the result of the implant will be. We have to check this well every 6 months or sometimes every 4 months. We do a checkup in order to make sure there is no inflammation in the gum. The patient has to have an excellent cleaning of this area in order to reduce the risk of bacteria entering the long epithelial junction. We have published one paper on this topic in Journal of Endodontics, and we know from a small research from Marcus Blatz from University of Pennsylvania that bacteria attachment, bacteria adhesion to different material, to nanocomposite is excellent. It's similar to that of zirconia, that you know is the material that better tolerated by our gingival tissue. If the tooth is not restorable, things change. We have to ask ourselves whether the tooth has a good crown to root ratio or not. In case it has an unfavorable crown to root ratio, we might have to do an extraction with ridge preservation. This is an example. We had to proceed with the extraction of the tooth. We have to do ridge preservation. In this case, we're using a material called mimeticose because it's synthetic. In Spain, in some hospitals, you are not allowed to give blood if you have received a graft from animals. So we are more using this type of materials. And once we finish our ridge preservation, we leave everything to heal, and we are able to deliver an implant with an excellent immediate static result. This is on 1 year follow-up. So implants do work well. In this case, I think she's 28 years old. She has a short face, and that makes it, I think it will make it more stable. It has also a tissue graft, by the way, but it will make it probably more stable in the long run. But still there might be problems. But implants work well if you work with them correctly. Let's see this lady. She was around 40 when she came. She had a crown on tooth 2. It had fallen several times. She was not happy with her dentist. She came to us in this situation, and the tooth was not restorable. The root was short. It was broken very deep in under the gum and under the bone. So we had to extract this tooth. Okay, so but in this case, if we pay attention to the case, it's a thin biotype, scallop thin biotype, and that means that the bone in the buccal plate is not at 3 millimeters, but it's significantly deeper, and that make it a more difficult case to restore with an implant, although of course we have the 2 pickup bones, mesial and distal, but it's not that easy. So instead of proceeding with extraction and risk preservation, we started, I didn't have my orthodontist with me these days, so we start pulling it. We start a slow orthodontic extrusion, 1 millimeter per month, 1 millimeter per month, in order to bring all the tissues down with the tooth. Okay, and we proceed in this way to our orthodontic extraction. And once the tooth was extracted, an immediate implant was placed. In this case, we did not use tissue graft, so, and it's stable after 15 years, so it ran well. Now we almost routinely place tissue graft in interior implants in order to improve the stability of the tissue, the volume of the tissue in a long run. But in this case, it worked well because we improved the volume of hard and soft tissue by pulling the tooth with the orthodontic treatment. In cases where the crown-to-root ratio is favorable, then we have different options, mainly 3: orthodontic false eruption, surgical extrusion, or crown lengthening. Very seldom we use crown lengthening, you will see. I will try to present a case of each. Let's see a case of orthodontic extrusion. This patient it's a recent patient. I had attended a course from Ignacio Lo. You might have heard about him. He's a wonderful prosthodontics, and he has developed an excellent technique to prepare teeth. So the patient, this is a young patient, 25 years old patient, has a lot of wear, I know, but he's very young. He dances capoeira in a boat, and he fall down and broke this lateral incisor. I have the dates here. So we didn't want to pull it out and place an implant. The root was long, so we could achieve, thought that we would be able to achieve a good crown-to-root ratio. So we proceeded with the root canal treatment. We placed the post. We prepared the post space, but we did not place the post yet. And we isolated well. You see how it is. We fill it with composite. Then we placed a wire that goes directly. It's prepared to go directly in the axis of the extrusion. And when with a coil, we start pulling it. It's important always to cut all the fibers around the tooth in order to not to break the tissue with you. In this case, we start pulling in a fast motion. So this is a fast orthodontic extrusion. That's 1 millimeter per week. Before we saw it was 1 millimeter per month and without fibrectomy. Okay. 1 week later, we pull again, and 2 weeks later we have gained enough tissue to prepare a crown. At that moment, we clean thoroughly the inside of the canal, we place a post, and after the post, we do a composite restoration, direct composite restoration. And after finishing the restoration, we have to splint the tooth to the neighbor teeth, for if not, the tooth will go back in. And in this case, we did it with some flowable composite. After that, we've polished thoroughly, and this is what we gain. We came from the left slide to the right one. See, this is the gain of ferrule for the tooth. This is 48 days later. And then, when everything was stable, we start preparing the tooth. In this case, we used BOPT technique. You will see the index ray. It's a vertical preparation. And if you are able to attend one course from Ignacio Loy, I strongly suggest you to do it, because it's an excellent way of treating these patients. But I won't present cases in this way because it's not the object of the lecture. This typical BOPT preparation, you have, or I have to polish it a little bit more, but you see that it's a vertical preparation, but instead of coming like a knife edge, it goes almost 90 degrees out of the bone. It's a little bit less than 90. It should come down here, and this provides an excellent support for the tissue. In fact, sometimes we gain vertical tissue without doing graftings with this extraordinary technique. And this is the day we delivered the crown. The patient hasn't came back, for he's in a boat now, and he will stay at least 3 months, 4 months in the boat. When he came back, I look forward to take a picture. But I just wanted to present the way we work, and also in the way that Ignacio Loy works. The second option we have is surgical extrusion. It's more problematic it's more risky. This picture taken 10 years ago to a patient. This was, at this time, it was 80 years old. He came 9 years later. You see the X-rays, and you see that he broke his central, his right apocanine, maxillary canine. He had a wedding of a granddaughter, and he wanted to smile well in 1 month time. So we decided, attending, and he was 90 years old at that time, to go with direct composites in the anterior zone, using BOPT technique also with direct composites, as you saw. We didn't plan to restore this. Remember, he was 90 years old at this time, and we had to decide what to do with this tooth. One option was doing a direct restoration, but we were not very sure if it will work properly. So we decided to do a root canal treatment, place a post, do a restoration like in composite, and at this moment we decided to do a tooth extrusion, but in a surgical way. So with the forceps, we tried to move it lightly, and as we were able to move it, we pull it a little bit down. Then with a wire, in this fact it was the same needle we use for placing anesthesia, we splinted the tooth to fix it in that position, and this is 15 days later. The correct thing to do there would have been to allow it to heal better, but what we did was a different thing. We directly placed the crown, and this is 1 year control, and it's working excellently. It didn't enter too much inside, although we didn't wait in this case. But in this case, we didn't want to wait because we only wanted statics for that time. We're gaining time and trying to deliver a good result. He didn't want to restore this part. He had enough with what we offered. All these things are a little bit shown in this paper published by Maciek Thorough. We helped him in his publication, but it's his work. It's a new classification system for the restoration of root-filled teeth. I suggest you to try to look at this paper because he explains, although not in depth, these concepts. Another option we have is crown lengthening. Very seldom we use crown lengthening anterior zone, for when doing crown lengthening you spoil aesthetics, especially in patients that are showing their gums. And even if they don't show, they raise their lip and they see it and they don't like it. So very seldom we use this technique. But sometimes we find patients as this, that they want to improve their aesthetics, and in order to improve these aesthetics, they do need crown lengthening. So in this case, he wants aesthetics. The first thing we did is determine whether this tooth was in good condition or not. In the X-ray, we see something there. We decided, in order to improve the diagnosis, to take a CBCT, and in the CBCT, we see that this was an image caused by the post, but there was nothing showing risk of fracture there, so the bone was in good health. But we saw an apical lesion. We removed the crown. You don't see it here, but this post, coron post, casted post, goes very deep in the palatal part, so there is no ferrule for a good crown. Anyhow, we saw that it was restorable, so we decided to do an apiectomy, a retrofilling with MTA, with sutured, place a temporary crown, and started, when it healed, with the crown lengthening. And now we have a lot of tissue. Now we have the opportunity of delivering a crown with an excellent prognosis. So then we place some temporary crowns the same day, as you see. And this is how it healed. So now we have a crown that it has enough root on one side. We improve the aesthetics of the patient, the gingival aesthetics, and the crown has ferrule, so it will work well for time. It's a very reliable treatment. And remember that even when everything fails, still a tooth rather than an implant. That's our philosophy. Let's show an example. This is my wife's nephew. He fell down in the school and he lost his right upper incisor. He had an avulsion. I was traveling at that time, so I was not in the office. He finally contacted me and I sent him to the school. The tooth had been out of the mouth for 3 hours, so the prognosis of the tooth was really, really bad. In case you replant such a tooth, it will for sure have an ankylosis. And that's what happened. Anyhow, I told them to place it there, for it's a way we can keep the bone and the tissue more or less in place. Most of the patients suffering avulsions in the anterior zone, the children, especially children, have angle class 2, many times division 1. And that's the case of my wife's nephew. Many of the patients with class 2 division 1 need extractions and orthodontic treatment. And in this case, we made a consultation with the orthodontic department, and our orthodontist told us that this patient would need not only extractions from the upper jaw, but also extractions from the lower jaw, premolars. That offer us an excellent opportunity, for we know that a transplantation from a lower premolar to a central incisor has a very high success rate. In some series, they have claimed 100% success rate, but clearly over 95% of success rate. So we planned to do an autotransplantation, and the best moment for the autotransplantation is the moment where 2/3 of the root of the premolar to be transplanted have been developed. When that thing happened, we prepare the patient, we extract the premolar, we extracted the central incisor, start drilling with a bar similar in size to the size of the premolar until we were able to place the premolar in the socket. Remember, it was an ankylosis, so there was no root there. It was mainly bone mixed with some rests of dentin. Once the tooth was inside, we stabilized it with some sutures. Sorry for the bad quality of these pictures. And the periodontal ligament recovered perfectly. So in 15 days, we were able to remove the sutures and the tooth was stable. At that moment, our orthodontist started the orthodontic treatment of this patient. The orthodontic treatment continued. We tried to, little by little, remodel the palatal aspect of the premolar. I never turned the picture taken with a mirror. This is the premolar. So we cut off the cuspid in here. We place some composite there. And this is how it looks. Of course, there is a disproportion between these two teeth. So we need more space here. With the orthodontic treatment, we will try to gain it. We have to intrude this a little bit and do a composite. So these two teeth look more alike. It's important to see how there is no root canal here in the picture. The disappearance of the root canal is sign of good prognosis. It's not a problem. This is some years later, and this last picture I took to the patient. I take a video so you can see there is no trick here. And in the photograph, we see in the 14-year follow-up how this tooth is perfectly integrated in the rest of the mouth. This is the transplanted premolar. This is a small class 4 broken in tooth 2-1. So you see that this is an excellent treatment and it has an excellent prognosis. Interestingly, people, when we show these kind of things, they think that we are playing, that we are inventing, that we are doing some type of experiment. And that's not true. If you go to the literature, you will find plenty of these treatments done many years ago, decades ago, with an excellent result. So it's a reliable treatment, provided you're doing it in an appropriate manner. Now we have changed a little bit the protocol, and the protocol, I will show it with a different case. Look, this 22 years old girl lost her first lower premolar, mandibular premolar, molar, sorry, and she wanted to have an implant there. When we look at her, we saw that she needed extractions of the third molars. So we told her, listen, you will probably need an extraction of the third molar. Why don't you allow us to try to do a transplantation of this molar to the place, to the socket, or to the place where you should receive the implant? And then we can, in the worst case, we can postpone implant placement, which it won't be bad. How do we do this? We know that the most important to improve prognosis is to reduce the time that the tooth is out of the socket. For that reason, instead of extracting the tooth as we did in the prior case, and go drill and locate the root and the transplanted tooth until it perfectly fits in the created socket, now what we do is a segmentation of the tooth to be transplanted. So with any program for that, you can use many of them. I like to use Sirix for this. We do the segmentation and we obtain this tooth. This tooth is exported as an STL, and if you want this STL, you can import it in a program to work with STLs. There are many of them, and then you can improve the quality of the surface, as I'm doing now, and then you send this to a printer, and the 3D printer brings you the tooth replica you have in the left side, which is very, very, very similar to the real tooth. You see the curve it has in the apical portion. So when we were drilling the socket, we saw that the only way to fit this there would be to cut the tooth in here. So we cut the replica first, and we follow with cutting the real tooth in the same location we cut the replica. And with that we are able to place the natural tooth inside. You see there is not much root inside the bone. We didn't want more root in the bone. We can extrude this a little bit to make bone increase, or just wait until it fails and then go for the implant. The patient will be much older. Once the tooth is stable in the mouth, then we can proceed with the root canal treatment. Okay, let's see another anterior case. This patient was referred to us from Malaga by his orthodontist. She was 10 years old at the time, and this tooth was ankylosed. This tooth is ankylosed, so there's no way, there's nothing we can do for this tooth. But the orthodontics determined that we could extract the left second premolar. So when the left second premolar developed 2/3 of its root, we started with the procedure. We removed the ankylosed tooth, and then with a replica fabricated with from the CBCT of the lower arc. So this is a replica of the premolar we are going to extract from here. You see that the tooth has not been extracted yet. We fit it in there. We drilled using drills in order to make room for the replica to enter. And at that moment, you see a comparison of the replica and of the real tooth. You don't have this apical papilla in the replica, but teeth are very, very alike. And then we extract the tooth and straight bring it to the prepared socket. So the extraoral time is minimal, is less than a minute. Once in there, we stabilize it. You see it? Once in there, we stabilize it, and in 3 weeks later, the patient comes back, and with a composite, we are able to deliver a result it's very, very alike to natural tooth. We leave it in this position because it is the position more interesting for us. So let us give you what I would say our take-home messages. First is, implants are an excellent tool to replace missing teeth but do have problems. Longevity of compromised teeth surpasses by far that of average implants. Many times to try to gain time is an excellent option. We recommend you to revisit classic techniques and combine them with new technologies and knowledge. And remember that interdisciplinary management of restorative techniques offers excellent options. So let's say that many times try to gain time, revisit classic techniques, and manage your cases interdisciplinary if you want to provide your patients to the standard of care today established. During the lecture, we have presented different procedures: endodontics, such as root canal treatment, retreatment, apical surgeries, intentional replantation, tooth replantation, restorative such as adhesive materials, prosthodontic techniques, periodontal as surgical extrusion, bone tissue grafting, GTR, tooth transplantation, decoronation, crown lengthening, orthodontic false eruption, orthodontic extraction. So we've seen many different techniques, and the only way to deliver these techniques to your patients in a reliable manner is working interdisciplinary. I am very happy to have an excellent team of people. Jose Espona, who is an excellent periodontist, and he has gone through a certificate in periodontology and master in prosthodontics. Fernando, who is the chair of endodontology in our school. Akram, who has been the chair of preventive dentistry and is an excellent restorative dentist. Cristina Sanchez, who is an excellent orthodontics. Natalia Felipe, she has a master in TMJ and mandibular dysfunction. Elena, my daughter, who works in ortho and pedo, and myself. So all together, and sometimes even cooperating with some maxillofacial surgeon or other specialists, speech therapy, physiotherapy, or others. So the key for us is interdisciplinarity.
Well, it has been an extremely pleasure to be in this meeting with you, and I have to thank again the organizers, especially Joao, for his kindness to us all by organizing this extraordinary meeting, and for considering me for talking to you in this exceptional week. It has been a pleasure, as I told you, and I open to any question you want to address me. You have my email, I wrote it down, you could see it before. And I hope you enjoy this lecture, and I hope you enjoy all the lectures you are having throughout the week. Thank you very much indeed.